Well, hello, everybody. Welcome to today's live webinar hosted by ATTAC Consulting. My name is Garrett Schmidt, and I'm the managing editor for BBC Exhibit Hall. And I'd like to welcome you to joining us today. We have a very exciting webinar planned for you, and it is titled Ongoing OIG Risk Adjustment Scrutiny, the top 3 insights for ACOs, payers, CINs, and providers. Actually, that has changed a little bit. I'm going to read the actual title, which is Ongoing OIG Risk Adjustment Scrutiny, Top 3 Insights for Payers, Risk-Bearing Providers, Clinically Integrated Networks, and Accountable Care Organizations. So all apply. So very happy to have you with us today. A few items of note before we get started. Everyone's joined the webinar today in listen-only mode, so meaning that you don't need to worry about muting your microphone or turning off your camera. That's been done for you. But we do want to hear from you. So we are going to have a time for Q&A toward the end of the presentation. So if you have a question at any time, go ahead and ask that, if you would, through your control module. There's a place for questions on there. It's different than the chat. So go ahead and drop your question in at any time. You don't need to wait until the Q&A. And we're going to get to as many as we can during the allotted time. If we don't get to yours, don't worry. Someone will reach out to you via email afterwards, and we'll answer your question. So even if we're wrapping up at the last minute, go ahead and drop your question in there. And then finally, today's session is being recorded. So what's going to happen is when we're done, I'm going to send out, or one of us will send out, a link to the recording. And that way you can review it and share it with colleagues, or watch it again. And there will be also a link to where you can find out some more information about ATTAC Consulting. And then finally, you will also receive a copy of the slide set, and you will be receiving an email from Mr. John Gottwald that will have the answers to some of the polling questions and some of the other things. So anyway, we'll mention that towards the end, but without further ado, I'm actually going to turn it over to Mr. John Gottwald. He is the Senior Vice President of Sales and Marketing and Client Services with ATTAC Consulting, and he will introduce our other speakers today. So welcome, John.
All right, thanks, Garrett. Appreciate that intro. All right, I'm going to, get off the cover page. Welcome, everybody. On behalf of the entire team, I will be your host. So depending on your age, I can be your Bob Barker, I can be your Richard Dawson, or your Steve Harvey, but that's going to be my role today. And some of you on the phone know of us. Some of you are clients of ours, and we've been around for 20 years this year. It marks our 20th anniversary. You can see what we specialize on the right. Obviously, the first one being risk adjustment, and we support various lines of business, as you can see right there on your screen. So we are fortunate to be joined by these two handsome gentlemen today: Alan Bratton, a senior consultant with ATTAC Consulting, and John Rogers, also a senior consultant with ATTAC Consulting. And between the two of them, they have over decades of experience in not only risk adjustment, but also health plans, providers, IT, as well as project management. And they will be giving you the best of their knowledge today on our topic, which, speaking of topics, as you can see, our agenda is going to be action-packed with all kinds of insights around the OIG audits, implications for various institutions, strategies, threats, and obviously what you can do to improve those outcomes, and also a few things at the end that we'll talk about what ATTAC Consulting can bring to the table. So without further ado, we are going to jump right into our first polling question. What conditions were identified as targeted conditions for an OIG diagnostic code audit? Select all correct answers. So basically, we are testing your knowledge. So I'm going to launch this poll. Let's see. All right. Again, you should see a poll on your screen. Please select all the correct answers. And we'll give it a few here to get everybody's vote in. All right, we got a little bit over 50% that have voted. Okay, we'll give about 10 more seconds to get your votes in. And again, select all correct answers or all that apply. All right, I am going to close the poll. Okay. And I'm going to share. So you guys should be able to see the polling results. Looks like we had a wide disbursement of selections here in our top 4 answers here. The correct answers are A and B. So it looks like most selected A and B. So it looks like most people got the right answer. All right, well, thank you for participating in that poll. And I'm going to turn it over to Alan Bratton, again, our senior consultant, and he's going to kick off his section. So Alan.
Hey, good morning, everybody. As we're all probably aware, the OIG is actively auditing Medicare Advantage plans, and they're targeting a list of diagnosis codes that they consider high risk, at a high risk of being miscoded. Over the last about 27 months, they have published 25 audit reports. These have been targeting, reviewing plan years 2016 and 2017. And what the OIG is essentially doing, they've got all the data. They're not asking plans to submit them data so that they can review it. The OIG is using CMS files that are already in their possession. And they're evaluating the data and then selecting plans for audit. And the process that they're going through is they're using that data and they're selecting a universe of member years based on the criteria for the 10 high-risk conditions that they've identified. And then from that, they're pulling a universe of up to 30 member years per condition. So 30 acute stroke, 30 acute heart attack, et cetera, right down through. So there's roughly about 270 cases that are selected for each audit. So to date, of these 25 audits, there's been about 4,700 cases, or 4,700, a little over 4,700 member years. 3,400 member years have been in error, and the overpayment estimate for that universe is about $8.3 million. The average is a little over $500,000 per plan. When CMS when the OIG applies the extrapolation logic to that $8.3 million grows to $427 million, and the extrapolation is essentially evaluating the total universe of cases that met the criteria that the OIG has set out for these 10 conditions. Again, I want to drive home that this is not a case where a random selection of a plan, hey, I'm going to look at your data. The OIG is continuously looking at this data, identifying concentrations of these conditions so that which would trigger an audit of a health plan. The other thing to point out here is the size of plans has ranged from about 9,700 members up to 588,000 members. So it's not like a small plan is excused from this. If there's a concentration of these conditions, that plan is just as likely to be selected for review as a larger plan. Next slide, Jen. So when we aggregate the substantiation or the pass rate, these are the 10 conditions that have been identified, and one of them is kind of a condition and a half or half condition. So the OIG is looking at acute stroke, heart attack, a combination of stroke and heart attack, and then embolism, vascular claudication, major depressive disorder, and then cancers, lung, breast, colon, and prostate. They started out looking at miskeyed codes, but they've stopped including those in the recent audits because there were some codes that if they're just switch a couple of numbers, it could change the valuation of the diagnosis, consequently the HCC mapping. So across those 10 conditions, of the samples that the OIG has selected, over 70% of them have failed to be validated. So of the 30 acute stroke cases that were brought in, plans have tended to fail in justifying those diagnosis codes. So when, as you'll notice, vascular claudication and major depressive have a higher success rate. There's a lot more blue on those two middle bars. When you factor those out, over 90% of the cases have failed to be validated. So 70% across the total set of conditions. When you take out the two high-performing conditions, you're at 90% fail rate. So this audit, if triggered for an audit, the OIG has a pretty high expectation that they've identified a list of conditions that they've identified a list of problems. You want to go to the next slide, John? Back at the Risk Adjustment Innovation Conference in, I think it's February, the OIG, as part of their slide, they said these audits are to identify situations that did not make sense and could cause significant overpayments. So what they're looking for, and this actually, the slide is from their presentation, they're looking for scenarios that would be unlikely. Somebody goes to a physician's office and has a stroke, and they are not hospitalized, they don't go to an outpatient hospital, inpatient hospital, that is an odd scenario that they're going to be looking at. If somebody has lung cancer diagnosed, but there's no treatment for that beneficiary plus or minus 6 months from that diagnosis code, that is a scenario that they think is unlikely, and they're going to look at. So these are not kind of nuanced type of things. These are things that once detected, they easily stand out. But they're also looking at, they're working with their experts, and they're saying, what does a diagnosis pathway look in a normal situation? So again, going back to a lung cancer diagnosis, what would you expect to happen? Probably a follow-up with an oncologist, probably some medications, et cetera. If they're not seeing any of that evidence, then again, that scenario would stand out, and it's going to show up in the audit. And they're also looking at medications and procedures for some of these conditions, as I just mentioned with lung cancer. Is there medications or follow-up procedures or visits? With major depressive disorder, is there medication in the record that they're seeing evidence that the beneficiaries having their drug claims filled, for example? If those cases are not there, that case looks odd, it's going to show up in the audit, and they're going to pursue that.
Yeah, and Alan, one small correction, that Risk Adjustment Innovations Conference was in April in Orlando. And if you were there, if you recall, it was at the Caribbean Royale, I think.
Thanks, John. I was there, and I forgot what month it was in.
No worries.
All right, so generally what the OIG is looking at is acute stroke and/or acute heart attack, single diagnosis code in a physician setting, no hospitalization. Major depressive disorder and embolism, there's a diagnosis code with no pharmacy therapy at all. The person's not taking any medication for it. Vascular claudication is a little bit more complex. They're looking at a single diagnosis with nothing else in the prior 2 years. And they're also looking for a crossover for neurogenic claudication. And then on the cancers, they're checking to see if there's a diagnosis code with no treatment in plus or minus 6 months. So, kind of just taking a look at that, and do they pass the smell test? Those do look like they would be scenarios that plans should follow up on. Just kind of anecdotally reading through those. Next slide.
And before I go to the next slide, just a reminder that Alan's going through a lot of information. The slide presentation will be distributed after this webinar, and then, as Garrett mentioned, there will be a link to this recording as well.
So when you look across the 25 audits, I've actually filtered out, there's only 21 audits here. I filtered out 4 of them because they didn't give this level of detail in the report. But when you look at the universe of, or the sample that was tested in each of the audits, the plans were able to successfully substantiate between 15.7% and 44.7% of the sample. So less than half across the board was successfully substantiated. And the failure to substantiate fell into really three categories. Number one, the documentation was insufficient. So when they looked at the record, it did not support the diagnosis code that was being claimed. Number two, there was no documentation available. So when they went to look for the records, there was no record that would be used to substantiate the diagnosis code. And finally, the third major category was that the wrong provider type or the wrong source for the information. So diagnosis codes need to be a clinician that's qualified to diagnose. And if the records weren't from a clinician that's qualified to diagnose, then that case would fail as well. So really those three categories are what the majority of these cases fell into. There's one or two other outliers, but those are the three. The largest being that the documentation was insufficient. Next slide.
And just as a summary, Alan, could you summarize those three real quick?
Sure. Category number one was the documentation is not sufficient. So they were able to pull a chart, but the chart didn't substantiate the code. Number two, there was no chart available, so there's no documentation for the code. Number three, when they received the information, it was from an unqualified source. So in many cases, that was using a lab record for the diagnosis code or an X-ray for the diagnosis code. There was no clinician that stated the diagnosis code or qualified clinician.
Great, thank you.
Then similar to what we saw earlier, these are the conditions and the pass-fail rate. And again, when you look at heart attack, the acute stroke heart attack, that's a 5% substantiation rate. And when you look at the cancers, an 8% pass rate. So, you know, what this is telling us is there is an industry-wide, won't necessarily call it a problem, but there's a variance between the OIG and CMS's expectation for how these cases would be documented and what the industry is doing. And so the OIG has said, you know, based on these criteria, those are overpayments and should not be made. Specifically in the cancers, a lot of the recommendations are if somebody is diagnosed with cancer with no treatment plus or minus 6 months, that should probably a history of cancer as opposed to a active cancer diagnosis. History of does not map to an HCC, so you don't, you know, there's no rate adjustment for that. Cancer does. So that variance is what they're chasing is we're diagnosing after an active cancer when the reality is the person's probably in a history of type of scenario. All right, we had 3 insights in the title, so I had to give 3 insights at least. So here they are. Number one is data. The OIG is analyzing data that is readily available to them. It's also readily available to you as health plans and as provider groups. And I'll talk about at-risk provider groups here in a second. So the data is available. The question is, and the criteria are very objective. So it's really a matter of pulling the data and taking a look at it. And the OIG in their presentations, they said this is a data analytics type of challenge. You need to put the testing of your data in place to find these scenarios and then act on them. Which leads me to number 2. These scenarios can be proactively detected. We don't have to wait 7 years for an OIG audit to say, oh, oops, something happened. If there's active scenarios playing year over year, those things can be detected through monitoring the data in your health plan. And then they can be acted on to resolve. Sometimes the resolution is going to be we need to delete the code because it can't be substantiated. Some cases it may be we need to go get some chart information on this. In some cases, the plan may stand pat and say, look, this is appropriate, which is kind of my third item on that bullet is, if you have a process in place to detect these things and then resolve them, it puts you in a better position to defend the cases that you've said, no, that case is appropriate, we've looked at it, and here's the reason. We've talked to an oncologist recently. He said, in certain age groups, certain cancers, the pathway that's selected is sometimes to monitor it and come back in 6 months and see what the next phase should be. So active treatment is not always the course that's selected, but the health plan and the provider group that's dealing with that case should be in a position to have evidence that says that's a proactive decision we've made, not an oops decision, we got caught. The third item is time, money, and opportunity. The OIG to date the reports issued to date have been for prior to 2017. And CMS has come out in their, I think it's the 2023 final rule or 2024 final rule, and said that we're not going to use extrapolation logic for any of these paybacks prior to plan year 2018. So if you remember a couple of slides back, the value of the sample was $8.2 million. But when you extrapolated that out, it was $427 million. So the industry right now, for the audits that have been published, is liable for the $8.2 million. Going forward, there's a possibility that that $427 million problem is going to come into play, because what CMS is going to do essentially, this is very simplified, but if you had a sample of 30 and you only substantiated 10, okay, so that's 1 in 3, then we're going to take your whole universe and we're going to apply that same ratio to that whole universe, and so that's going to be the value of what you need to pay us back. So that's overly simplified, and probably some actuaries are not happy with my simplification, but essentially the penalty or the payback is going to be much, much larger in scale for plan year 2018 going forward. And the good news is the rules are published. You've got an opportunity to act on these proactively and get these issues resolved. Then the bonus insight is this affects more than health plans. At-risk providers can be severely impacted as well, depending on your contracts with your payers. Let's go to the next slide. So as a provider group, if you're in a value-based agreement or a risk-sharing contract, and there's a wide variety of these, so if you're in this category, you've probably got a variety of these types of contracts that you're entered into. You're probably dealing with a wide variety of provider or of payers, and those payers may act on this differently. So what does your posture need to be if you're in that situation? Question number one, from a financial impact perspective, does your contract with the various payers that you're working with allow for those refunds to CMS to flow down to you as a provider? And if it does, do you know your risk, and do you have reserves, which can go out 5 to 7 years? So understanding kind of the lay of the land with the health plans that you're dealing with, and then also understanding, is there a financial impact that could present itself 5 to 7 years down the road? Are you prepared for that, and have you quantified that? From an administrative perspective, questions to ask are, do you have methods in place to detect and address these in similar other cases? The health plans are processing claims and submitting data to CMS for cancer and for heart attacks and all that stuff. The care associated with that is at the provider level, right? So if you have somebody that you're seeing that you've diagnosed with one of these conditions, are you aware of it? Are you measuring the patient's compliance with their care plan to know that somebody, I diagnosed them with lung cancer, they've not followed up with their oncologist, their prescriptions are not filled, any of those types of activities, if you're at risk for that member, that would be good information for you to have, whether or not they're following up with their plans. And also your clinical staff and your administrative staff, are they aware that the OIG is looking at these? The OIG is looking at these 10 conditions because it's low-hanging fruit. That's not to say that 11, 12, and 13 aren't on the way, but these are the 10 that, if they affect your patient population, would be helpful if you're aware of. And then also collaborating with your health plans, reviewing contracts, obviously, but also what recourse do you have? You know, if Health Plan A is going to be out there in advance of this and get all over it, and they're going to delete codes and, you know, they're going to clean things up, that's helping manage your risk if that risk flows down to you. If Health Plan B has decided we're going to just roll the dice and see if the OIG ever comes to calling, how do you insert yourself into that to make sure that you're protected? So collaborating with the health plans on those types of decisions can help manage the risk of the provider groups. And then, as I mentioned earlier, kind of quality of care questions. If members are not following up on their health plans, do any of these conditions, do they point to a member care scenario that if you have these types of conditions show up, following up with those beneficiaries to make sure that they're following up their care plans. So making sure that this isn't pointing to, this is either an administrative problem with the data, with the records, or this is a quality of care problem that needs to be addressed. And we'd recommend that both be looked at if you're dealing with, you know, scenarios that fall under these conditions.
All right, thanks. Thanks, Ellen. All right, so that brings us to our second polling question. In a nutshell, have you evaluated claims and risk adjustment records and quantified your risks for an OIG audit? I'm going to launch the poll. You should see a poll on your screen. This should be an easy one. All right, about half the people that voted. We'll keep it open a couple more seconds here. All right, we'll go ahead and close the poll. And it looks like the majority have said yes, but we have more work to do. And only about a quarter said no. So, which also means more work to do, or work to do as well. All right, thank you, Ellen Bratton, for all of your insights. And now I'm going to turn it over to John Rogers.
Thanks, John Gottwald. Well, with that polling question, it's kind of a backdrop of what do we do about it now, right, across the various organizations. So what we have up here is a framework of kind of best practices as to how do you go about addressing these OIG high-risk diagnosis codes. And really, this is a 30,000-foot look. We're going to drill into each of these 4 buckets here in the next slides. But really starting out, we have this is, again, as Alan mentioned, this is primarily a data exercise, right? So first and foremost, either the development or acquisition of the analytics required to identify these cases that are going to be problematic, right? And so with that becomes a rules development, which is the blending of both data team expertise as well as clinical team expertise. So kind of that collaboration between 2 groups to appropriately define your rules or your data sets that are going to be used to identify those high risk situations or cases. Along with that then is establishing from the onset the governance as to how are those data sets being first and foremost agreed upon, reviewed, vetted, as well as then what are the downstream procedural steps taken by the organization once those have been identified. So the next step would then be quantifying the impact. So once we have established our rules, determining what is the OIG high-risk universe when it comes to these high-risk diagnosis codes. And then from there, it's getting sense as to what is the failure rate or the substantiation rate or lack thereof of those cases. And that's going to help to estimate then the risk score as well as the financial impact, very similar to what we saw in the 21 published reports. From there, once we understand what kind of the exposure is, it's conducting that root cause analysis to really identify and pinpoint where are the opportunities to rectify this. It comes down to looking at the data and looking at the trends, right? Is this really at a group level? Is it a particular facility? Or looking at a specialty, for example, or is this more of at a geography level? So understanding what are those main drivers and what are those root causes, which then flows directly into the final step, which is ultimately mitigating the issue, right? So implementing that mitigation plan, we have kind of a historical cleanup component of it, as well as then a go-forward process. So that's where we have deleting codes when applicable, as well as then educating, and then your ongoing monitoring, as well as kind of other operational components going forward. All right, next slide, please. Okay, drilling into that first bucket, which is really looking at the development or acquisition of the analytics, right, is we have to look at bringing to the table those individuals that have the insights and the subject matter expertise in defining what are the correct diagnosis codes and therapy codes for these conditions, as well as then teaming up with the data folks to make sure that at scale across the entire organization, the organization can then actively monitor and mine the data to identify this low-hanging fruit, right? And so the diagnostic criteria, it's that code set, but then we also have the therapy codes, right? So those are, pharmaceuticals, whether they're scripts or J codes. This could be surgery, this could be radiation, this could be immunotherapy, et cetera, right? So what are all those different therapies that we would consider applicable to each and every one of those high-risk diagnosis code cases, right? And then looking at the interplay between diagnosis as well as therapeutic scenarios, and also you have your time constraints. Alan spoke to, it's going to differ based upon that category type, right? Cancers versus your claudications, right? Versus your acute stroke and heart attack, et cetera. So ultimately, establishing that governance structure early on is going to be really important, right? Because you're going to set the cadence for your code set review, as well as the actions to take on each of those high-risk diagnosis code types, right? So it's understanding, are we going to review this on a monthly basis, a quarterly basis, annual basis? What are the different subject matter expertises, whether internal or external, that we're going to tap on and bring to the table to ensure that we have the right therapeutic code set to make sure that we're not falling behind. I mean, with just the number of NDCs that are always coming out, either on a weekly, monthly, or quarterly basis, having a really good pulse as to new entrants into these spaces is really important, just to make sure that you have coverage across the board. All right, and then also then defining the procedural steps that the organization is going to take depending upon the scenario, right? So a couple, kind of different ends of the spectrum being automatic deletion. Whenever we see this sort of code set, we're just going to delete it versus, we're going to earmark this for medical record review. So each of those cases is going to take a little bit different flavor as to what is the action that is taken to ensure that we have accuracy of diagnosis codes. And then finally, it's just really staying abreast of all the different trends within the industry, new OIG and CMS developments, and just making sure that the analytics are always refreshed to reflect that. Next slide, please. Okay. So once you have really the analytics core built out, it's really running through the data of your organization to find a high-risk universe, right? And so the first thing is to quantify that for each contract. Now, for the payers out there, it's looking at the different H contracts, and by year. On the provider side, it's looking to see what the exposure is across all the different payer partners, right? And understanding then, as Alan mentioned before, what are the contracts that we have in place with our payer partners, and how does this influence that, right? If we look through the lens of that contract, what is the exposure to our organization when it comes to these high-risk diagnosis codes, right? In order to actually quantify the error rate, once we know what our universe is, there's typically two routes to go with, right? So either we have a 100% medical record review or a statistically significant sampling of that, right? So in that case, if you're doing a 100% medical record review, it's relatively easy to do a risk score impact determination. But if you're using a sampling, you have to extrapolate out what that looks like, right? And ultimately, once we understand the risk score impact, we can estimate our financial impact, right? So there's the impact of what has happened in the past. If we need to clean that up, which is going to ultimately then we need to make sure we're reserving for that, and or looking at risk adjustment premiums going forward, right? Do we assume that we're going to receive lower risk scores and then therefore lower premiums in the future, right? And then ultimately, how is this influencing contracting and value-based arrangements? Okay, next slide, please. All right, so once we figure out what's our financial and risk score impact, it's then looking at root cause, right? So every organ is going to be a little bit different on this one, but understanding, is this a primary care versus a specialty sort of drivers, right? Are we seeing trends? Do we have hotspots in a particular geography? Is this provider group, provider system, a specialty? Is this specific rendering providers that has a disproportionately higher prevalence of these versus care delivery modality, right? Is this at the clinic level? Is this telehealth related? The other thing that we consider, right, is this coming through in what we deem kind of normal encounters and or claims flow? Or is this a unintended consequence of some of the interventions that our organization has that are often like vendor driven, right? Think in-home, in-office, telehealth assessments, or medical record review, right? So understanding where are the volumes of these cases coming from helps us to understand then how do we apply the right mitigation plan. Next slide, please. Which really is, okay, for those cases that are substantiated, it's a very clear guidance from CMS that those deletions need to be sent through, right? And there's a path forward for that. But then as we look at, once we've cleared our backlog, and then how do we address the problem going forward, we have education, right? So we have education of our staff, education of providers, as well as education of vendors to make sure that everybody's on the same page as to what are we looking for and what are the implications of that. And then going forward, right, so we're looking at internal checks once the claim is received, but before it makes it outbound, right? And so then you also have mitigation strategies that include it into the medical record review portion, accept and encounter review and cleanup. So instances in which a diagnosis code did make it to either the EDGE server or CMS, being able to review and clean those up, as well as ultimately then once we have our programs in place to really address this, ensuring that we're pressure testing it, right? And really ensuring that we have all the angles covered. And oftentimes you can use kind of an external review, whether that's an external department within your organization, so like not the risk adjustment department as an example, or just an outside entity to take a look at that. All right, next slide.
All right, John, you get to take a breather. Brings us to our last polling question. Does your organization have a policy, procedure, and method to detect outliers for high-risk diagnosis codes, quantify the impact, and resolve them? So you should see a poll launch on your screen. So A, yes, B, yes, but it's informal, or C, no. All right, we got about half voting, so give another few seconds here. All right, I'm going to close the poll. And it looks like we got about 3/4 yes, either yes or yes, but it's informal. All right. Thank you for participating in that. And I'll turn it back over to John.
Thanks, John. So the kind of that set of slides that we just went through, it was very specific to how do we address this particular, what I'll call scenario, right, of these OIG high-risk diagnosis codes. But if we take a step back and we look at how do we integrate this diagnosis code accuracy throughout what I'll call the entire end-to-end spectrum of risk adjustment, as well as really data submission practices, right? So really, taking a look at each of these components through the lens of diagnosis code accuracy, because really that's what this is all driving towards, right? Is really trying to drive towards making sure that data submissions are as accurate as possible, and this is just low-hanging fruit, right? So with that in mind, the application is really to all lines of business. When we talk about Medicare, ACA, and Medicaid in terms of those submissions, and really the implications are across prospective interventions, retrospective chart reviews, data submissions, as well as engagement on the provider side. So we'll drill into each one of these here in the next slide. All right, next slide, John. Okay, so when we talk about prospective interventions, really the way that we're framing this is prospective activities are really trying to drive that face-to-face encounter between the member or the patient and the provider that's going to be considered eligible for risk adjustment consideration, right? And so I've bucketed kind of passive versus active prospective interventions, and really the passive is more so on the data sharing component. So if you think about something, and this is just one example, right, of member engagement, right, or patient engagement, where either the health plan or the clinic could make outbound communication to the member to encourage them to go see their provider, right? And that's pretty much the extent of the involvement there, right? Member goes see their provider, they address what is important to them at that point of care, right? Whereas yesterday it's more active when it comes to data sharing. That could be, in-home telehealth or in-office assessments, in which oftentimes you have health plans are providing information to the provider as to, hey, this is all the information we have in terms of the clinical picture for the given member. And really, it's a more robust sort of assessment to ensure that all conditions are being addressed, right? So with that more active sort of prospective intervention, quality controls need to be in place, right? In which, SLAs of 95% or greater in terms of coding accuracy, which is pretty much an industry standard, is in place, as well as things like, is the diagnosis code appropriate for the setting, right? Are there diagnostic capabilities that are required, either testing or imaging, to make that diagnosis code, right? And is that being considered as we are looking at these programs from a quality control perspective, right? So, as an example, right, place of service, right? Is a condition appropriate for the place of service, right? So if an acute stroke or acute heart attack is being coded in an in-home assessment, but we're not seeing an emergent referral after that, two parts, right? Is that appropriate for that care setting? And if no, are we seeing any sort of emergent referral then, flow through, or case management referral after the fact from typically these are oftentimes vendors, right? So ensuring that we have some of these other controls in place to make sure that we have really robust oversight of the program is important. Next slide, please. On the retro side of the house, really what we're trying to do here is ensure that diagnosis codes submitted to CMS are accurate based upon the clinical documentation, right? So it starts with targeting. In this case, we have to look at it both sides of the coin, right? Those diagnosis codes that we believe are missing, as well as those that have a high probability of being erroneous, right? That's where this, high-risk diagnosis code universe comes into play, right? Is looking at both sides, right, of the coin and making sure that we have both upside and downside coding, right? And so part of that also is having coding actually SLAs in place, in which we have greater than 95% coding accuracy thresholds, either for internal staff or for vendors, right? And then ultimately, that comes into supplemental record reconciliation and ensuring that our adds are added, our deletes are deleted, and everything is accounted for by the time it makes it to CMS, which is a dovetail into the next slide, which is really making sure we have robust data submissions. So from an end-to-end perspective, do we have continuity, line of sight in terms of monitoring and reporting and ensuring that not only are we seeing all the data flow, that we're not having any leakage at every single one of these handoffs, but are we also tracking these high-risk diagnosis codes throughout the continuum, right? And do we have checkpoints in place that in which we know when we see these codes at a particular step in the process, that we know to look, what to look for, and what our action and mitigation plan is, and then are we then monitoring downstream from there to ensure that when appropriate, those are being withheld or deleted, right? And so we look at this in terms of all the inputs that come in, whether that is organic claims, whether those are extracts from our vendors or from another benefit in terms of it could be vision or whatnot, or PBM, etc. So ensuring that we do have a really robust and monitoring program in place. Okay, next slide. And then finally, provider engagement, right? So it's really equipping the providers with the tools, resources, and support from the health plan perspective to get accurate diagnosis coding. And so leveraging the advanced analytics in order to pinpoint, hey, what are those provider groups that are really honed in on where can we provide the most support to these providers, and then meeting where they are in terms of on a communication and technology level to ensure that the right level of engagement is there. And then ultimately for health plans, we all hear about provider abrasion. So how can we team up with other provider-facing functional groups in order to really come in arm in arm and really make sure that providing that support. Okay, John, back over to you.
All right, thanks, JR. Okay, so that concludes most of our slides around the topics today, but we do want to talk a little bit about what we can do for health plans. And if you look at the first detection of the first four, is detect a problem. We actually offer a risk assessment based on the 10 OIG criteria that we went through. And you can reach out to me and I can tell you more details about that. But that second bullet is more what I want to focus on is what we're offering at no charge to the health plan. The first 20 health plans that take me up on this offer, we are going to run a summary of one H contract for 1 year free of charge. And we develop our analytics and tool to mirror what CMS would do in such an audit. So we've actually got the analytics. I wouldn't say we're testing them because we're pretty confident in our analytics, but the first 20 health plans that sign up before the end of summer, basically August 31st, we will run those for you and send you those results. So feel free to send me an email. My contact information as well as Alan's and John's are at the end of the slideshow. And then we also offer various levels of, as you go along the spectrum, as you will. We've got a full assessment report, right, that could be run for 2018 through 2022. And then we've got other, you can see we've got other various assessments that address the problem or prevent the problem. I'm not going to read those to you, but these will be in the slide deck, which some of you have asked in the question box if this will be provided. Yes, it will. So please take a closer look at these. If any of those resonate to what you're going through, please reach out to me or any of the speakers on this webinar today, and we can certainly give you more information about that. So again, the second bullet on the first chevron there, we will be offering that for the first 20 health plans that reach out. All right, and if you do have any questions, some of you have used the chat box on your on the control box there in the webinar, or you can contact us directly. Again, our contact information will be at the end of this presentation, which will be available for you. And again, we will be sending out the link to the recording of this webinar as well. All right, with that, I'm going to turn it quickly back over to Garrett. Actually, I'm sorry. I'm going to go through all the questions, then I'm going to turn it over to Garrett. So I do have some questions in the question, but I just seen if he was listening. So
quick note about that, John. Actually, real quick, if you do have a question you would like to submit it, now is the time to do so. We're going to get to as many as we can during the allotted time, but don't worry, if we don't get to yours, someone will reach out via email afterwards and answer your questions. So you have a little area on your control module for questions, which is different than the chat. So if you could drop your question in there, we'll get to as many as we can. So take it away, John.
All right, thanks for that, Garrett. Okay, so I'm going to read some of the questions, and then Alan or John, feel free to jump in. These guys are the experts. So the first question is, should smaller health plans be as concerned as the larger plans for the OIG high-risk diagnosis codes, given that audits have been for bigger age contracts historically?
John, I'll take that. This is Alan. So I would say yes, historically they've been larger plans, but there have also been some small plans. I cited there was one plan that had, I think it was 9,800 members that had a report written against it. So I would say small plans are more vulnerable if they're subject to an audit because financial reserves are kind of harder to come by. So I would say the risk is higher now of if an audit were to happen, the impacts impacting them in a greater way. So I don't know that small plans are excused from this process.
Yeah, I would agree with that. All right, thanks, Alan. Next question. For health plans that haven't actively begun to address the OIG higher risk diagnosis codes, what are the recommended first steps?
I can take that one. This is John. So I think, if we talk about, kind of think back on that framework, the first and foremost is making sure from an analytics perspective that you can wrap your arms around the situation, right? And then it comes into identifying that universe as well as then trying to quantify what the error rate would be for your organization so that you can start to size the implications and the impact based on, risk scores and ultimately financials, right? So I think it's starting with the data exercise and really trying to understand how big of a volume we're dealing with is probably a really great first step, and especially focusing in on, what would be in scope for extrapolation methodology with that RAVI final rule. So, starting with payment year 2018 to date would be kind of the first place to start in my mind.
Okay, thanks, John. Appreciate that. All right, next question. How often and for what plan years should we monitor for high-risk diagnosis codes?
So this is Alan again. So I would suggest that first of all is what is it that you're trying to detect? If you're just wanting to see if you got a problem for an OIG audit, you can do it infrequently and for older years. If you want to monitor this to proactively get out ahead of it and also prevent these conditions from happening, doing it for more current years and more frequently will allow you to work the cases. So part of it is what problem are you trying to solve? I think we would recommend, number one, looking at 2022, 2021 are good years to be able to look at. You're still within the risk adjustment with 2022 dates of service. Those are active. You've probably still got providers that if you have trends, as John was talking about earlier, if you have trends in certain providers billing certain ways, you can still take effective corrective action. But you can also work those scenarios more concurrently, if you will, and those may still be active members with those conditions that need to be addressed in a different way. Looking at the years 3 to 5 out or 3 to 7 out, there you're looking for do I have a quantifiable risk that I need to address in some way? So that's a long rambling answer to say we would suggest that plans go from 2020, actively monitor 2023 because you've got concurrent care, but also start looking back to years 2018 to understand what kind of risk you have for a penalty in the future.
All right, thanks, Alan. Got one more question, and then I'll have to turn it back over to Garrett. I'm not sure this is a typo or not. I'm going to read the question, and hopefully we can figure out what the question is. Looks like there was either a typo or maybe a word was left out. The question is, Doesn't chart substantiate that doctors run tests in fear of being sued? I'll read the question again. Doesn't chart substantiate that doctors run tests in fear of being sued? And maybe it could be chart substantiation.
John, you want to take that?
Yeah, what I was going to say is, thinking through the medical record review component of this, the medical records are being reviewed to ensure that the diagnosis code, that is submitted to CMS is, supported by the documentation, right? And so I would say the biggest thing for health plans in terms of how they go about ensuring that they're taking the right approach to this is making sure that their coding guidelines that they have defined, within their own four walls, are being applied appropriately to the data that are being submitted. And really, from a medical record review perspective, that's the biggest thing that intervention or that program is really trying to aim at, right? Is ensuring that the diagnosis codes being submitted through CMS that are really impacting payment, right? Payment that's being received, premiums, right? So think about premiums being received to the health insurance companies, right? So in that regard, the lens in which we're looking at medical record review is more so, is the diagnosis code substantiated, and then does it warrant then the increase in premiums for the care that the member is receiving or should be receiving? John, back to you.
All right, thanks, John. Okay, that's all the questions we have time for today. So I'm going to quickly turn it back over to Garrett.
All right. Well, thank you all so much. And I know when we did have a number of questions that did come in, so if yours wasn't answered, again, don't worry. Someone will reach out to you afterwards and answer your question via email. So thank you again for contributing. As we close out here, first of all, I wanted to thank our speakers again. You guys did a fantastic job. There was a lot here, and we realized that you might want to review this. So we're going to be sending out a link to the recording, and also you'll be able to get the slides. And I believe John Gottwald is also going to be emailing everybody a version of the slides that will have the answers to the polling questions as well. So look out for that email as well. But on your screen here, you are seeing the exhibit booth for ATTAC Consulting Group, and this is a virtual exhibit booth at VBC Exhibit Hall. And this is where you can learn more about them and what they're doing in the value-based care space. And it's kind of a snapshot of what they've got going on. You can interact with their team and learn a lot more there. There's some great resources. So that's at vbcexhibithall.com. And then finally, if you would like to reach out to the ATTAC team, including our speakers or Mr. Gottwald, their information is here on this last slide, and this will also be included in the deck. So if you want to take a screenshot or wait till we send it to you, please do so. You can reach out to them, or feel free to reach out to me as well, and I'm happy to facilitate an introduction or connect you with the right folks. So thank you again so much, everybody, for joining us today. We really appreciate you being with us this afternoon, and hope this was a really helpful and insightful presentation for you. So thank you all so much for coming. Have a great day.